Great. Well, it's a pleasure to be with you all tonight. We are going to take time to talk about measles prevention and those updates for the transplant community. And as always, we will talk a bit about COVID-19 and some other timely infectious disease related issues at the end. But it's my pleasure to hand the mic over to Dr. Ayman Al-Jurdi, who will talk first about measles. Thanks a lot for being here. And as Stacy mentioned, please, we got some questions before online, and then please put your questions into the Q&A, not into the chat, but into the Q&A. Thanks.
Excellent. Thank you, Dr. Cotton. Welcome, everyone. I'm excited to be here, and we have a few things to go over with you, and we hope you'll find this session informational, and then at the end, we're going to take questions and hopefully, be able to answer everyone's questions. So first, in terms of our disclosures, I personally have nothing to disclose, and Dr. Cotton serves on the Advisory Committee on Immunization Practices at the CDC, and she writes book chapters about this topic. So let's go ahead and get started. So the outline of the topics we're going to talk about today are: what are the symptoms of measles? How contagious is measles? What are the potential complications of measles? And then most importantly, how can we prevent measles? And then we're going to spend some time at the end doing some sort of general updates about infectious disease topics, and then we'll take the questions. So let's get started. So what is measles? So measles is an infection that's caused by the measles virus, which is a highly contagious virus. And the symptoms of measles, there's several symptoms. The most common symptoms are a combination of fever, a red blotchy rash that starts on the forehead and spreads downwards, red eyes, also known as conjunctivitis, runny nose, cough, sore throat, and white spots in the mouth. And so, as you can probably tell, a lot of these symptoms, such as the fever, the runny nose, the cough, can be seen with a lot of other things, common colds, influenza, etc. And so some of the clues that make us think about someone potentially having measles are the white spots in the mouth and the rash. So what you're seeing here on the left is a picture inside the mouth of someone who has measles. And what you can see are these white spots that are on the inner side of the cheek. And these in the setting of a viral infection are very suggestive of measles. The other thing is the rash, which classically starts on the forehead, is red, and spreads downwards. And so that, in combination with the other symptoms we discussed, makes us think about measles. The other things that make us think about measles are also the exposure history. So it's very common for people who develop measles to have been first personally unvaccinated and previously uninfected, and also to have either returned from abroad or have been exposed to someone who has returned from abroad and picked up the measles there. So these are some of the things that I wanted to highlight in terms of the symptoms of measles. And an important point is that you don't really have to have all of these symptoms to have measles. Transplant patients, because of them taking medications to lower their immune system, can actually present with, not all of the classic presentations. So you could have all of the features without the rash, for example. And so, it's important to know all of the symptoms, but to also recognize that you may or may not have all of them. Great. And so why is this important, and why are we talking about this today? I think the two main concepts that I want to sort of emphasize are, we're talking about this today because first, measles is highly contagious, and the cases are, we're seeing a lot more cases these days. And the second thing is that it can be a really serious infection. And so these are sort of the two main points that I want you guys to take from our talk today. And so let's delve into some of the details. So about 1 in 5 people in the US who get measles will be hospitalized for measles. And so that's, that's sort of an evidence of how serious it can be. And let's talk a little bit about how contagious the measles is. And so the measles virus is one of the most contagious viruses. And the reason is it's spread through airborne, spread in the air when someone coughs or someone sneezes. And in fact, if one person who has measles gets in contact with 10 people who are not immune to measles, that one person can infect on average 9 out of the 10 people. And so you can imagine one person infecting 9 people, each one of those 9 people then going on to infect another 9 people, etc. So it can really spread very quickly. And the other thing is actually the measles virus lives in the air can live for like 2 to 3 hours. And so even if someone, for example, who has measles and is coughing and sneezing, goes into a small room, coughs and sneezes, and then leaves, and then someone else walks in like an hour later, they could still potentially be infected. And so it's highly contagious. It stays in the air for a while, and so it's definitely something to be concerned about. So unfortunately, despite sort of the best supportive medical care, still 1 to 3 out of 1,000 people who develop measles will die. And part of that is because, unfortunately, we don't have an effective treatment for measles. So there is no medication that is, approved to treat measles. And so despite supportive care with, for example, supporting the person with fluids, treating their fever, and giving them a chance for their immune system to fight it, people, unfortunately, can still die from this infection. But the other point I also wanted to make is when we're thinking about why measles is such a serious infection, is thinking beyond the just are you going to be able to stay home or get hospitalized, or are you probably going to survive the measles or not? Because most people survive. But the other important thing is sometimes people may survive the infection, but still end up with a complication that really affects their quality of life. And I would say in measles specifically, the most important one is a delayed neurologic complication that is called SSPE, or we can sort of abbreviate it as encephalitis, which is basically inflammation in the brain that can happen even years down the line after someone gets measles. And it can manifest with symptoms such as changes in behavior, in cognition, even seizures. And so when we're thinking about the importance of preventing measles, it's not just preventing the acute illness or the death from the acute illness, but also really preventing long-term complications that can have a real impact on someone's quality of life. And what I'm showing you here in the MRI is just an illustration of the inflammation in the brain that we can see here in white as a delayed manifestation of the inflammation in the brain from measles. Okay, and again, emphasizing the point, the reason this is such a big problem and why we really need to prevent measles is we also don't have treatments. And so there's no real antiviral treatment to prevent measles. And so that's why prevention is really key. And so now we're going to switch gears. I hope by now that I've convinced you that measles is highly contagious, is a potentially really serious infection, especially in immunocompromised people. And so now what can we do about it? So let's take a step back and look at sort of the history of measles cases in the United States. And what I'm showing you here is a chart of the number of cases of measles reported in the United States between 1962 to 2023. And what you can see on the left side is in the 1960s, the cases were really prevalent. So we would have around 400, 500,000 cases a year in the United States. And a big turning point was the creation and licensure of the vaccine for measles, which happened in 1963. After that, the number of cases for measles went down significantly. And so, the number of cases went down significantly. And, the second dose afterwards was recommended in 1989. And in the year 2000, the measles was actually declared as eliminated in the United States. The number of cases was low because of the vaccination rates. And so this was really, really great. Unfortunately, this has somewhat changed in the last couple of years. And so now what I'm showing you is the number of confirmed measles cases in the years 2020 through 2024. And as you can see, after a long time of barely seeing any cases, now over the last couple of years, we're starting to see cases of measles again. And in fact, in 2024, we're not even halfway through it, and we've already have more cases in the United States compared to all of last year. And so these cases are on the rise. And a lot of this, unfortunately, is due to the fact that people are not getting vaccinated for measles. And so people who are not vaccinated are much more likely to get it and then to spread it to other people. And so when we're looking at people who get measles in the United States, the majority of them have either themselves recently had a trip outside the United States or have been exposed to someone who had traveled recently outside the United States. And so most of these cases are acquired abroad. And so that's part of why actually people who travel abroad, you know, tend to go to travel clinics where we sort of counsel people about the importance of the vaccines to get before they travel abroad to protect themselves and the people around them. And one of the vaccines we emphasize in that settings is the measles vaccine. And so let's talk about the measles vaccine. So the measles vaccine is available as a combination vaccine. So it's a vaccine that covers 3 viruses: measles, mumps, and rubella. And so the vaccine is abbreviated as MMR for measles, mumps, and rubella. And this is a live viral vaccine, which means that it can cause disease in people who are immunocompromised, such as transplant patients who are on medications that lower the immune system. And so when we're thinking about the measles, mumps, rubella vaccine, let's review the CDC recommendations. So the CDC recommends people to get the MMR vaccine unless they have what we call presumptive evidence of immunity, which means that you have something to show that you are likely immune to measles. And the categories for these things are one of 3 things: either prior vaccination, a positive antibody test, or being born before 1957. And so let's go through all of these things. So for the first one, in terms of confirmation of vaccination, so this requires having written documentation that you've had prior vaccination. And there are 2 sort of levels of vaccination. So for people who are at average risk for measles, this has to be at least 1 dose of the MMR vaccine that is given at least after the 1 year of age for people who are sort of at average risk for transmission. Or if you're someone who is at higher risk for transmission, for example, you're a college student, you travel abroad, you work in healthcare, for these people, they're considered to be at higher risk of getting measles. And so these people actually, per the CDC, require 2 doses for them to be declared immune. And in fact, in general, it's probably better for most people to just get 2 doses because it's very common for people, obviously, to either go to college or go abroad or, be in healthcare settings. And so I would say in general, 2 doses of the vaccine. The other way that you can prove that you're actually immune to measles is actually by doing a laboratory test, which is an antibody test. And an antibody test, if it's positive for measles, it means you've either had measles before or you've had the measles vaccine before, because either of them would result in you having sort of an immune system response and then having a positive antibody test. And then the last thing is the CDC actually accepts being born before 1957 as presumptive evidence of being immune to measles, because at that time, you most likely had the disease. The disease was very prevalent, and the vaccine was not available at that time. And so just to recap, so people who do not need to receive the MMR vaccine are people who either have had prior vaccination, 1 or 2 doses, depending on the risk. If you have laboratory evidence to antibody testing showing that you're immune, or if you were born before 1957. But this applies to the general population. So let's talk a little bit more about sort of what we do here and how this applies to transplant patients. So at the MGH, for the last 20 years, we have been checking measles serology on all patients pre-transplant, and then vaccinating them if they are negative for measles. So we've been checking the antibody levels, which is the second category of knowing if someone is immune or not. And then we found that in general, about less than 5% of people were actually negative when they came for their pre-transplant evaluation. And these people were recommended to receive the measles vaccine. Now, an important thing to note, because the measles vaccine is live, and so can actually cause disease in people who are immunocompromised, if someone is going to get a transplant and gets the measles, mumps, rubella vaccine, you actually have to wait at least 4 weeks between the vaccination and getting a transplant, because if you are exposed to immune suppression too close to the vaccine, that could put you at risk for actually developing clinical disease from the vaccine. And so that's why really the only time we can vaccinate people against measles is before the transplant. Moving to the second point as a continuation, so we do not actually give the measles vaccine, the MMR vaccine, after transplant. And we strongly discourage people from getting this. And this is because there are reports of people who've actually had serious disease from receiving the live measles, mumps, rubella vaccine after when they're immunocompromised. And so there have been reports of serious lung infections and serious nervous system infections. And so at this time, with the amount of information that we have, we do not recommend receiving the measles, mumps, rubella vaccine after transplant. And so all this, and that's why a lot of our emphasis is on getting this done before the transplant. So let's say you're someone who happened to not have received the measles vaccine before transplant, and you've never had measles before. What are some things you can do in terms of protecting yourself? Well, part of it is actually making sure that the people who you surround yourself with are actually immune to measles. Because if they're immune to measles, even if they get exposed, they're less likely to get it and less likely to transmit it. And so what we do is we encourage close family members and loved ones and friends to actually, if they have not been previously exposed or previously vaccinated, to actually get the measles vaccine themselves, so that this way they are protected and in a way they can form a circle of protection. And then moving to the last point, which is, I think, very important in our discussion here for transplant patients, is let's say you have, let's say you were exposed to someone who had measles. So let's say, for example, you have a family member who traveled abroad, came back, was sick. You happen to see them while they were sick, and then, the next day they develop a rash that looks like measles. They get tested and they're positive for measles. And so then they call you and tell you, hey, I know I saw you 1 or 2 days ago. I actually tested positive for measles. What should you do? And so in that setting, what the CDC recommends is that for anyone who's been exposed, who's severely immunocompromised, who's been exposed to measles, to actually receive a medication called immunoglobulin within 6 days of exposure. And the timing here is very key, to be received early. And so what immunoglobulin is it's basically antibodies. So it's proteins in the blood that are filtered from people who've donated blood. So when people donate blood, the blood is filtered into its different parts. One of the parts is antibodies. And these antibodies are actually then sort of concentrated and filtered. And they're from the general population, many of whom are vaccinated. And so they contain antibodies to the measles virus. And so if you've been exposed to the measles virus and you call your within the 6-day window, and you call your transplant physician, they should be able to refer you to get the immunoglobulin medication, which is either an infusion or a subcutaneous injection. And the antibodies against measles within the medication should then help by sort of making sort of like a circle or a bubble around the virus. And this way reducing your risk of actually getting sick from the actual measles. Perfect. And so I'm going to wrap up the measles discussion by just sending it back to Dr. Cotton to tell us about a study that she is currently working.
Yes, so there are a lot of questions around measles. That was a very nice summary of state of the art. But so we are looking to do additional research evaluating the immune response to measles before and after transplant. And so if people are interested in participating, basically we request that you donate several tubes of blood to us. And then if you are getting a vaccine prior to transplant, we might do pre-vaccine and then post-vaccine sampling. And if anyone's interested in participating, you can call my office and leave your name and number, and I'm happy to follow up. Otherwise, I will just do some additional infectious disease highlights, and then we'll go on to the Q&A because I know some people have questions. Right, so happy news. COVID-19 disease activity is actually way down. This is national data on emergency room visits, and this is from the CDC. you can see that although we had a pretty good peak around the end of 2023, since then, numbers have really declined pretty significantly. So that is wonderful news. Next slide, please. And here's Massachusetts. I know not all of you are in Massachusetts, so we did national data and then local data, but you can see that in sort of at the end of last year, we had over 20% of emergency room visits were due to respiratory infections. And then our numbers have really fallen for COVID-19, influenza, and RSV. You can see they're really just 0.4% overall of visits relate to COVID-19. So that's really good in Massachusetts as well as national. Next slide, please. You've seen this slide before, if you've seen prior webinars, where we look at the amount of virus in wastewater. So this summarizes the northern and southern parts of Massachusetts, the Water Resources Authority, and they basically sample virus in the wastewater. And you can see that our numbers as of just a couple of days ago are really very, very low. And so that's, you know, wonderful. Next slide, please. There are a lot of questions about where we're going with different vaccine strain types and what's happening. You can see that, as always, the virus continues to evolve. There are some new strains out there. We think that these new strains should be well protected by our current vaccines. But you can see that things are ongoing, evolving, as always. Next slide. And so just to highlight that for COVID-19 prevention, and this is really important, all moderately or severely immunocompromised people over the age of 12, so that's all transplant patients, should have received an updated COVID-19 since last September. And if they had a first dose of vaccine, it's recommended that they consider getting a second dose of the vaccine at least 2 months after the last dose. That's CDC language. I'm actually, to make it simple, transplant patients should be getting a COVID-19 vaccine roughly every 6 months. Unfortunately, many people have not gotten that first dose of the booster. People are telling me, oh, I had vaccine several years ago. That vaccine is pretty much gone, and so they're not well protected. So if you haven't had the updated vaccine, you should definitely get one now. And if you had the updated vaccine maybe last fall, you should probably get another dose roughly 6 months apart, but a minimum of 2 months apart. And then there've been a lot of questions about the new monoclonal antibody, this pemivibart or Pemgarda, that is now commercially available. It is approved under emergency use authorization by the Food and Drug Administration, and for immunocompromised patients who are at least 12 years of age and at least 40 kilograms. Now, in some ways, this is sort of like Evusheld, and many of you potentially got Evusheld, except that in the modern era, with numerous doses of vaccines, we are not seeing the significant infections that we were previously seeing in organ transplant recipients. And it's not clear that this monoclonal antibody is really necessary for organ transplant recipients. I would rather encourage people to get 2 doses of the vaccine. Vaccine protects people by developing an immune response within the person. And so that on an ongoing basis, part of the reason that we're seeing so much less disease and less severe infection overall is that we have multiple vaccines. And so our immune systems are really triggered. Monoclonal antibodies are just these passive antibodies that provide some level of protection. We are likely not going to, there's no plan at Mass General to roll this out large scale. It requires a 1-hour infusion and 2 hours of observation because of the risk of a severe allergic response. And so I know there've been a lot of questions about this, but in general, it is not being used, and there's no clinic to sign up for. There's no place to go for this. And it would have to be given in an infusion center, and as I mentioned, for about 3 hours. So this is not something that I think is widely needed. What is widely needed is for transplant patients to be up to date on their vaccines and to get a vaccine every 6 months or so. Next slide, please. So I get a lot of questions about, well, the pandemic's kind of done. Can I just stop wearing a mask? So tragically, no. I think it's still a really good idea for any of us who don't want to get sick to wear a mask. Not necessarily all the time. If you want to wear a mask all the time, that's fine, but certainly in higher risk locations. So when you are in crowded places, if you are, um, in a crowded store, if you're at a concert, if you're in an airport, boarding an airplane, sitting in, with lots of people around you, I actually wear a mask on a plane. I have no interest in getting sick. We know that masks work. And so I would encourage you to use your masks wisely. And then, they protect against so many other infections as well. So it's a good idea to not give up the mask entirely. Obviously, you can do what you feel most comfortable with, but I would encourage maybe more selective mask wearing now that we have a lot more protection than we did. But just be thoughtful about when you're going to wear a mask. Next slide, please. Also, it's the summer season, and as an infectious disease specialist, I need to remind you all just to avoid mosquito bites. There are a lot of things that can come from mosquitoes. We have West Nile virus. If you're traveling down to the south, especially to Florida and the Caribbean, you think about things like dengue, dengue fever, Zika, chikungunya, etc. Here we have Eastern equine encephalitis as well. Basically, try to avoid mosquito bites, wear clothing to cover up against mosquito bites, and then use insect repellent that contains DEET in the lower left-hand side of this slide. DEET, D-E-E-T, is the best. Picaridin is also pretty good. So, yep, thank you for highlighting that. Those are both good agents and really very safe. I read a lot about DEET when I was pregnant and going into the area where there was West Nile virus. And actually, the major issue with DEET is if you drink it. So do not drink your insect repellent. But otherwise, it's really very safe if you're just using it as a topical spray. Next slide. Oh, and just be careful about ticks as well. There are a lot of tick-borne disease. So if you're traipsing around in tall grasses or areas where there are ticks, wear repellent. Check for ticks, especially after you're hiking outside. Make sure you check. Ticks love going where there are body folds, so kind of anywhere that there's an area they can hide. So the groin folds or underneath the armpits or in the neck area, wherever there's a little area they can burrow, they love those. So just do tick checks and then let us know if you're having any symptoms or concern about tick-borne disease. Next slide, please. And so that's it. I think there are a couple of questions that had come in earlier. So Dr. Algerdi did highlight some of the answers to these questions, but basically, if I had measles as a child, do I still have immunity? And do you just want to readdress that? If you had measles as a child, are you protected now, Dr. Algerdi?
Yeah, I mean, I think, yes, if you've had confirmed measles infection and your serologies were positive at the time of transplant, that does tell us that you probably have immunity going forward. Now, we do know that immunosuppressive medications can potentially impact sort of long-term immunity, but you're sort of as protected as you can be if you've had it before and your antibodies were positive at the time of transplant.
Yes, so we really think that most people who have prior history of measles or who have a prior positive antibody should be fine and should be protected. But again, just to emphasize, especially if people maybe miss this part, we don't recommend that any transplant patient get a measles vaccine now if they're on immunosuppression. So if they have an active organ transplant, they should not get the measles vaccine, at least not without a careful discussion. And then I see another question. Just to reiterate, family members of transplant patients post-transplant should make sure they are vaccinated for measles. And yes, they should. The best way to protect a transplant recipient is either the transplant recipient should be vaccinated themselves, and they should surround themselves with people who are well vaccinated. We have another question for infusion for COVID. There are infusion centers popping up everywhere, including Bedford, New Hampshire. Given that, would you be more likely to recommend the infusion? So I'm not sure which infusion they're giving. It could be remdesivir for treatment, but it could be Pemgarda, the monoclonal antibody. It's interesting if there are infusion centers popping up, that means that they see a commercial opportunity. And so I'm not against getting it, but it's not something that's going to be offered large scale at Mass General for everyone to come in and get an infusion. I honestly am not compelled that people need to get that, but I do think that everybody should have a dose of COVID-19 vaccine every 6 months or so.
Yeah, and it's definitely not a replacement for the vaccine if you choose to get the Pemgarda.
Right.
So,
And then, go ahead.
sorry, Dr. Cotton. There was a question that was submitted in the registration. They were requesting an update on Pemgarda. If you had more information on that.
Yeah, I think that, so I sort of mentioned that, so it is available. It should cover circulating strains now. I think though it's not really needed for transplant patients who are well vaccinated. You know, many transplant patients have had over half a dozen vaccines at this point. And when you are vaccinated, it means your body's own immune system can fight off infection. So that's kind of the update. Again, this isn't something, we get a lot of messages, can I please have Pemgarda? And okay, great. So there's the infusion center in Bedford is giving Pemgarda, and Medicare and insurance cover it. Great. Yes, so that is good. I will say that there is a significant risk of allergic reaction. So, and it does take a long time to get in the infusion. It's an hour for the infusion and 2 hours of observation. But for people that want to do that, that sounds reasonable. Do make sure that your insurance covers it, because it's being covered under Medicare, but not necessarily other insurance coverages, and it could be expensive. I see another question about, what about RSV? I got a vaccine in October. Is that enough? As far as we know, we're only doing 1 dose of RSV vaccine at this point.
Okay, and then there's still a question. There's another question back to the COVID in terms of treating non-severe COVID in transplant patients who have been vaccinated before. I mean, at this time, we're still treating people who are previously vaccinated. We have a few options, you know, Paxlovid, remdesivir, molnupiravir, depending on what medications you're on. So at this time, we are still treating like moderately severely immunocompromised transplant patients. And so definitely, if you have COVID, let your transplant provider know. And then back to the measles vaccine. Did you mention that you should still get a measles vaccine even with prior immunity from already having measles? So if you've had measles before and you have antibodies against measles, which you most likely would, you don't need the vaccine. And if you're a transplant patient on immunosuppression, you cannot get the vaccine in general. But pre-transplant, if you've had measles before, you should have antibodies to measles, and in that situation, you should not need to get vaccinated.
And then there's one more question that we got during registration, which was, should all transplant patients get a shingles vaccine? And I would say yes. If you've not yet had the newer shingles vaccine called Shingrix, it's 2 doses of vaccine, either before transplant or after transplant. I usually recommend at least a year after transplant, when you're more likely to have a good vaccine response. But we strongly recommend that all transplant patients, the CDC has recommended this for a few years now. I was actually the leader on that CDC panel that recommended the shingles vaccine, so I spent a lot of time thinking about this. And we do recommend that all transplant patients of any age, not just over 50, but all transplant patients get the shingles vaccine. We've recently had some pretty significant shingles, and it's heartbreaking to all of us when we see something that could have been avoided through a vaccine. And so we do strongly encourage people to get 2 doses of the shingles vaccine, either before transplant. You might have to tell the pharmacy that you're a transplant candidate or on a transplant list. or after transplant, and then again a year or more later. And it should be covered by most insurance plans, but I would ask. We don't actually stock it at Mass General because it's not so well covered by insurance at Mass General. It's like a technical issue, but you can get it at any of the commercial pharmacies, CVS or Walgreens or whatever. One little question, I did not get the RSV vaccine last fall. Should I get it now? We would recommend you get it in either August or September. So for people 60 years of age and over, if you didn't get the RSV vaccine last year, we would recommend that you get it probably, yeah, when around the time you're getting a flu shot and maybe even an updated COVID-19 vaccine.
Okay, and then I assume spouses should also be vaccinated against shingles. I mean, if they're over 50, they should definitely be vaccinated, even if they're immunocompetent. It's even for immunocompetent people, it's like a terrible disease to have. It's very painful and it's not worth it. So, yes. And then there's a question about, can folks over the age of 50 receive the RSV vaccine? Right now, it's recommended for 60 plus. And so that whether that's going to change for immunocompromised people, we don't yet know. But at this time, it's 60 and older is what is recommended.
We're going to be voting on that question at the end of June at the CDC. So hang on to your hats, and we'll see what the final decision is. But unfortunately, right now, it's not covered by insurance usually if it's under the age of 60. So it's a big issue. We don't actually think it's dangerous, but it may not be warranted.
Okay, and then there's a question about choosing between different COVID meds for non-severe disease. Which, if it's in the outpatient setting, I'm assuming that's what you mean. Our options are Paxlovid, Molnupiravir, Remdesivir. These are sort of what we're doing at this time. And part of it is, in general, Paxlovid or Remdesivir are preferred compared to Molnupiravir, but the problem with Paxlovid is it interacts with some of the immunosuppressive medications. So if you're, for example, on tacrolimus, you technically cannot take Paxlovid. And so we make a decision based on the medication interactions and the ease of being able to get you the infusions. So it's a combination of these factors. I don't know if you would add anything else, Dr. Khan.
Nope. Depends on drug interactions and availability and all of that.
And then there's a question about, are vaccines safe for kidneys and for CKD? Yes, they are definitely safe. So we know like CKD is a mildly immunocompromising condition, but you can still get live vaccines. You can get any vaccine. Is it okay to receive a COVID and flu shot at the same time? Yeah, you can. I mean, if your arms might be more sore, maybe you're more likely to have a fever, but it's definitely okay.
I say it's personal preference. If you'd rather have a little like post-vaccine feeling on 2 different days, or you could just get the vaccines on the same day and then just feel kind of lousy for one day. But that's personal preference if you want to spread it out or if you want to just get it all over with at once. One thing I want to say about flu shots and RSV and COVID vaccines, for anybody with poor kidney function, not yet on dialysis, I have been really impressed sitting on the CDC vaccine panel at the amount of kidney disease that we see that's a real risk factor for COVID, for influenza and RSV. And then we see people who are unvaccinated, who are not yet on dialysis, but these severe infections push them into needing dialysis. And so I would encourage people, especially if you have kind of borderline kidney function, to stay up to date on your vaccines as a really good way just to protect that remaining kidney function. And yeah, I'm a big believer in prolonging the life of the kidney and other, lungs and all of that for as long as possible. So vaccines can really not just prevent this illness, but prevent all the other things that can follow. And we've seen that again and again.
Yeah, and in fact, for some of the vaccines, actually, like people with chronic kidney disease, once you're on dialysis, your response to vaccines becomes a little bit less good, and then after the transplant with the meds, it's worse. So it's, in fact, before you, like if you have chronic kidney disease and you're not on dialysis, this is the time to get, the vaccines in. And then there's a question about masking. If you go into restaurants off hours, is it safe without a mask? And how long does COVID stay in the air in a restaurant? Dr. Khan, do you have any thoughts?
Yeah, so the less dense the restaurant, the less your exposure to other people. I will say it's pretty beautiful out there. We're still doing outdoor dining. It's New England. Take that opportunity to really relish the great outdoors. But if you do want to eat indoors, if you go when there's not so many people around. I mean, at the end of the day, if you're sitting next to the wrong person, there you go. But I think you can lower your risk by going in off hours, less, a Sunday night instead of a Saturday night or whatever it might be. Or you could even call the restaurant and say, when are you not busy? And those things can all decrease your risk. It's sort of a numbers game, but you can also get affected at any point just by bad luck. But think too about outdoor dining or picnicking. There's so many things that we found that were pretty cool during the cool part of the pandemic.
Definitely. And then there's a question about how long is the RSV vaccine effective, and how often should I get vaccinated? I mean, right now it's a one-time vaccination, although again, we can see if that's going to change. In terms of the duration of effectiveness, any new data out there, Dr. Cotton?
Yeah, so it's a new vaccine, so we're gaining a lot of information. One thing that we've seen is that when we gave a dose in year 2, like we gave a first year and then a second year dose, so we didn't actually see a booster effect. So we're pondering what to do about that, and we are gaining data. If I had to say something, it looks like we might end up giving RSV vaccines every several years. I don't know if it'll be every 3 years or 5 years. The work is underway, but right now it's not every year. And right now it's only recommended as a one-time dose for people 60 years of age and over. But again, wait for a month from now, we'll be voting on that very topic at the CDC. And so there may be changes. Yes, so to be determined.
Yeah, and maybe we didn't talk much about this, but we are talking all vaccines. Also, don't forget about the pneumonia vaccine, which is also like super important. And there's now the Prevnar 20 formulation, which I think a lot of people, especially have now, if you've had your kidneys or organs for 2 or 3 years, you probably had received sort of the Pneumovax 23, and so now you probably are eligible for the Prevnar 20, and so just that's something to also review with your physician.
Yes. And that's widely available at commercial pharmacies. So if you're in CVS, that would be a place to get it. The vaccines are the same wherever you get them. And I guess along those lines, it's the summer, people are traveling. So if you're going anywhere exotic, you might want to think about looking on the either CDC website. There's a CDC destinations website that lists all kinds of things about individual countries, or if you are definitely going somewhere exotic, I'm happy to see you in Travel After Transplant Clinic and updating vaccines and thinking about travel specific vaccines. That's always a happy visit. I love those. I'm happy to help support you travel to fun destinations. Great.
Right, so it looks like that was our last question. So one thing I'll mention is whenever we do these programs, we often get questions that aren't necessarily on topic, but more so questions like how long will I be on a wait list, so on and so forth. I just wanted to make the note that please contact your nurse coordinator. You all have a designated nurse coordinator who's great. They're a great resource, so please feel free to reach out to them. You can do that through Patient Gateway. And if you are not signed up for Patient Gateway, I can send you all the link to that and then you can get registered. But that's my little tidbit. Dr. Cotton, Dr. Algerdi, do you guys have anything else to say, to add?
I think the one thing I'll say is, when you're seeing your physician, whether it's your PCP or your transplant physician, sometimes a lot of things are happening and you're like dealing with a lot of things. So if they don't tell you you're due for this vaccine, I think just make it a point before you leave saying, am I up to date on my vaccines? What else do I need to get? Because sometimes, it's good to remind people, and I think that would be helpful.
Yes, I completely agree. Thanks to everybody for their interest in this topic. And yeah, well, this will be on YouTube, and we're really hoping that this was informative. We're actually hoping that we don't see much measles ahead, but we just wanted people to know what our program is and what we're doing. And if you are exposed to measles, to a known case of measles, then we would give you immunoglobulin potentially. So yeah. And don't get the measles vaccine if somebody offers it to you if you're on immunosuppression.
Please don't do that. Okay. Thanks, everyone.
Thank
Dr.
you, everyone.